angel wing shape configuration. If we look towards the right, so if we base it out of that one, we can see on the right that we've lost the margins. Now it's more difficult to see the ribs. Now it's more difficult to see the heart. So this is all being obscured by the infiltrates or the pneumonia that that developed from the COVID infection. And to be a little bit more subtle about it, when we look at the X-rays, things that can suggest more of a COVID infection, but not necessarily rule in or rule out, is the X-rays will show that the infiltrates are more subpleural and more peripheral. So it's an external area. So it's almost like it's coming in from the outside. Next slide, please. So this is a section of CAT scan, and the one on the left is a normal section. We call this the frontal section or a coronal section. And we can see that the lungs are, again, in that nice configuration of a wing, and it's pretty black or close to being black. And we see the diaphragm underneath at the bottoms. They're nice bow shape. So this is a normal CAT scan CAT scan for the chest CAT scan. If we look at the right on the contralateral side, we can see now that we see that now there's the infiltrates or the haziness that's coming from the more concentrated to the external side. So this is what we call subpleural infiltrates, and there's a mix of really opaque or white infiltrates, and also that mix of in between that gray and black, which we call ground glass. So ground glass just means it's not black, it's not white, it's kind of grayish. So it's just like a fancy term to confuse people, but yeah, that's what it is. So let's move to the next slide. And so when we provide oxygen, we can do it, there's a way to escalate things. And typically, as they come in, a lot of patients do start off with what we call a nasal cannula, so a small tube that goes underneath the nose, and it provides a certain amount of liters. So typically, it's in between 1 to 6 liters of oxygen. And if they need more, then we escalate towards a face mask, so there's less entrained air. But if those two are not enough, then we go to a higher level of oxygen delivery. So there's the high flow device that we have the mouse on. And so this high flow device provides, it's not just the oxygen that it provides, but it provides a higher liter of flow, even up to like 70 liters or 60 liters. And this high flow of oxygen, technically what it does is it takes away the dead space ventilation. And with that, it improves oxygenation for a lot of these patients. And the downside with this one is for not necessarily for the patients, but for the providers, there's a discussion it can aerosolize the virus, which would make it more infective for the people caring for the patients. Same thing for the non-invasive ventilator or the CPAP or BiPAP. The CPAP probably a little bit more prevalent for treating COVID. The CPAP we would wear with a mask that's sealed, so it's almost like a closed system. Then there's a HEPA filter that we apply to it, so it doesn't infect the people around who are caring for the patients. But the CPAP provides extra pressure as well as oxygen for this patient. And if both fail, then we're looking towards escalating to a mechanical ventilator or intubating the patients. So used to be, typically when we say used to be, like years ago, no, but this is like a month ago, used to be, there was this discussion about using this for doing an early intubation. And when we do the early intubation, it means that, you know, as people are escalating their need for oxygen, then people are kind of thinking, okay, I should be intubating this person earlier. But more recently, with the New York data showing that a lot of intubated patients do poorly, now there's a thought process of, okay, now I want to hold back and be more and delay the need for delayed intubation for this patient. So other techniques to improve oxygenation would be proning, vasodilation, with things like NO or Velitri, and even providing anticoagulation for people that we suspect have pulmonary embolisms. Next slide, please. So this is a slide that shows proning. So proning essentially just means we put the person on the belly. So typically when patients are in the ICU, they're lying flat on the back, but when to improve what we call the ventilation and perfusion, we may put patients on the prone configuration. So this was initially shown from a study from 2013. It's actually not a new study from France that showed benefit for severe ARDS, which we've been seeing a lot in this COVID population. So going to the image on the right, it shows what we call a rotoprone bed. And so this rotoprone bed is essentially a big cage we put a person in. So to put it simply, it's almost like a rotisserie. We put the patient in, we close the cage, and we essentially just program it how much time the person spends in a particular side of their body. So it can be a benefit, but it's also challenging when you're trying to take care of the patient when they're inside it. It's almost like a cage. Next slide, please. So other complications we've encountered, septic shock, neurologic symptoms like delirium, strokes, Guillain-Barré, cardiomyopathies, arrhythmias, and kidney injury and coagulopathy. So a lot of research still going on. Septic shock, we treat with vasopressors to get an appropriate blood pressure to protect other organs. Cardiac-wise, it's a lot of it supportive care, trying to control the heart rhythm. We may get a cardiology consult for this patient, but otherwise nothing specifically directed towards the certain conditions right now. Next slide, please. So one interesting phenomenon that we've encountered more recently, or we've noted more recently, is what we call a cytokine storm. And it's essentially a hyperinflammatory state with organ failure. And it's typically triggered by viral infections, less than 5%, but typically includes at least fevers, low cell count, typically the lymphocytes. And when we check the ferritin level, which is a test that we've done for so long, but more recently have done a lot more, is typically the ferritin level is hundreds, but typically in the thousands if it's an honest-to-goodness cytokine storm. And a lot of these patients will have pulmonary involvement. Next slide, please. So the clinical implications to this one is there's available medications already out there to provide these patients. The downside is they're all investigational. There's nothing that's currently FDA approved for cytokine storm due to corona. So there's currently a UCSD phase 3 trial, which is expected to complete in October or September, and using Actemra to treat patients with cytokine storms. And anecdotally, it's been mentioned in the New York and even the Boston area to be potentially beneficial to the patients. So the downside with the IL-6 blockers, if there was an unchecked infection, it potentially could worsen that unchecked infection. So other things that could be provided would be an IL-1 inhibitor, as mentioned previously by the previous speaker. There's ongoing trials in the US, in Europe, and globally. And that's essentially the meat of the discussion. Next slide, please. So another thing that's been questioned recently is when to intubate somebody. Do we intubate early? Do we intubate? Do we try not to intubate? So I think essentially the thought process is if we provide other forms of oxygenation, can these worsen the pneumonia or the COVID pneumonia? So there's been prior data from China that says there's a high rate of failure with CPAP or BiPAP, and this can cause aerosolization, which would put the healthcare providers in danger. But the downside is with the New York data, now we're trying to kind of back off, and be more deliberate. So typically we want to do a non-urgent intubation, which makes it safer for the patient. And we will try to do a trial of proning even for those people who are not intubated. Next slide, please. Thank you.